Hi there. Welcome to The Preventable, the podcast giving you a seat at the table with conversations about the intersection of alcohol, drugs, and mental health in everyday lives. Take a seat and join us. Welcome to The Preventable. We are virtual today. We're coming to you from all parts of Missouri. Very excited about that. But before we get started, I cannot say it enough. We could not do what we do without Hubbard Radio, who has all kinds of radio stations that I know you all listen to all the time. The Point, The Arch, WIL, KSHE, ESPN Radio, and they donate this amazing studio space to us. So that's why your sound quality sounds decent. So really appreciative of Hubbard for allowing us to do this. Speaking of appreciative, I am so grateful to have Katie and Shanna with me today with MIMH. I got a call from John Gall. I think he's the only person who's been on the pod like 3 times. So he gets some sort of award or something. But he called me. I'm living in Alabama right now. He calls me and he's like, all right, you need to talk to these 2 women who are doing incredible things. And I said, okay, John. I said, do I need to ask what it's about? And he's like, no. It'll all make sense. And they're great. Just call them. So we're going to find out together. So welcome Katie Ellison and Shanna Sorg from MIMH, Missouri Institute of Mental Health. And we are here to talk about your Safer Homes Collaborative, right?
Yes, thank you. Thank you for this opportunity
You are welcome.
To visit with you today, and then also your willingness to shift to an all virtual platform. So thank you.
You are welcome. So, first of all, Shanna, just to kind of like make sure that we're all on the same page here. So, Safer Homes Collaborative, when we think about safer homes, there's lots of ways that could go. But we're talking specifically today about making homes safer mentally and physically, particularly as it pertains to suicide, correct?
Correct. Suicide prevention and reducing access to lethal means in the homes as a measure of suicide prevention.
Okay, so when I hear lethal means, I immediately go to guns. But I'm going to bet that that's not the only thing that we would want to restrict access to.
Correct. And thank you for having us today, Nicole.
You're welcome.
So when we think about lethal means, we think about any of those means that are used in suicide. Medications, firearms for sure, devices that cut, devices that can be used as a rope or something. Mm-hmm. We, Safer Homes Collaborative and our program, we focus a lot on the gun aspect because it is the most lethal means when we're talking about suicide. The statistics are 9 out of 10 suicide attempts made with a firearm lead in someone resulting in death. So when we're talking about this topic, we have to talk about guns and how people store their guns in their homes. Which gets into
so Katie.
Go ahead.
Right.
Sorry.
Yeah. So Katie, so you're trying to take away our guns, right?
Well, actually, not at all. In fact, you wouldn't want me handling your firearms for you. What we're trying to do is engage people in conversations. We believe that most gun owners have every intent of being safe gun owners and believe that they store their firearms safely. But we put some definitions around what does that mean? What does safe storage actually entail and look like? Of course, unloaded, locked, separate from ammunition.
Say that again.
Unloaded, locked, separate from ammunition.
Great.
That is the safest storage method to prevent unauthorized access to prevent accidental injuries and death, and then certainly also to prevent death by suicide when handling that firearm during a moment of absolute crisis. We are not wanting to take away anyone's firearms. We're wanting to raise awareness of that link between that increased risk for dying in a suicide attempt and the firearm. As Shanna said, 90% of the time when someone attempts suicide with a firearm, it's going to be lethal. Compare that to the medications or poisons that we have access to in our home. Most people attempt suicide by overdose, but only somewhere between 2 and 4% of the time that overdose suicide attempt will be lethal. So you can see such a great disparity. And why we are intentionally focused on the firearms. But we want to talk about the medications and the poisons in the home.
And locking those up.
Locking those up.
Correct.
If able, temporarily removing the firearms from the home, if that's an option, and the gun owner is willing to separate the firearms from the home. And then we provide several other recommendations and suggestions for, if there are barriers to engaging in the locked portion of the locked, unloaded, and separate from ammunition. Are there other steps that could be done to render firearms inoperable, such as removing the slide or the firing pin? Could we, if it's a revolver type firearm, removing the cylinder? If it's a rifle or a bolt action rifle, removing the bolt mechanism from the firearm so that it cannot be discharged in that extreme moment of crisis and despair. And so we're wanting to give gun owners the knowledge to think, oh gosh, it's hard, even for those of us who are trained to recognize warning signs and risk factors for suicide, to see it happening with someone that we love, or to recognize all of the direct and indirect clues about suicide risk. It's sometimes hard for us to see it, and we're the last ones to pick up on it in our home. So can we be proactive in how we safely store our firearms? Can we be, once we do know that someone in our home is at increased risk, we can be proactive so that they can continue to reside in our homes in a more safer environment, and that we're putting time and distance, we're making it more difficult for them if they felt despondent, if they felt despair, or they had that impulsive action, I need to end this pain right now, and they were to go to grab someone's firearm or their own firearm to end their life.
Okay, so I got a few questions.
No, I just rattled a lot off.
No, but I was taking notes. So, first of all, I know that some people might roll their eyes and, kind of say, like, well, why can't we just say committed suicide? I've heard you a couple of times, both of you, in this interview so far, really being intentional about your language. It's something that we talk a lot about on this podcast, is being intentional with language. So I'm wondering, just very quickly, Shanna, could you talk a little bit about what is the new person first terminology when we're talking about suicide, just to make sure that we're all making sure what we need to say and why we're making the change?
And I appreciate you coming to me, Nicole, but I'm going to turn this one back to Katie because she can explain it way better than I can, and I feel like this is a great opportunity. Yeah.
So when we use the phrase committed suicide, it harkens back to a time when suicide was pretty broadly universally seen as a sin. And we believe that suicide is the outcome of a lot of kind of like a perfect storm coming together, and when a person is struggling with mental health challenges, substance misuse or abuse, they're going through a lot of life crises and change, or they've experienced a lot of loss, they can feel desperate to end the pain that they're experiencing. And much like health conditions, mental health, everyone has it. And so we see this as a condition of the brain, a condition of the body. And so we don't commit cancer, we don't commit heart disease, we don't commit diabetes. And so we no longer want to add to stigma, and prevent people from reaching out and seeking help and saying, hey, I'm struggling. We want to talk about it in terms of died by suicide. There are some out in the field that make it a verb and say suicided. That's a little weird for me to
How about
say out loud,
completed
but
suicide? Is that still appropriate or no?
So it can be. When talking about, here's how I break it down in my head. When talking about an individual who has died by suicide, I don't want to connote a positivity or a success, kind of like, well, they completed a race, they completed the test,
or they attempted it or whatever, right?
Yeah. So, but if I'm talking about those who well, even so, I would say died by suicide using a firearm, there were, that's how I would frame it. You can talk about there are times when it's appropriate to use the term complete when you're talking about the universal phenomenon and not individuals.
Right.
So we don't want to ascribe positive attributes to suicide.
Got it.
Because it can contribute to a risk factor.
Got it. Okay. Which is that, and pardon me if I'm saying it wrong, but is that notion of like kind of the copycat kind of thing?
It certainly can.
Okay.
It certainly can contribute to it. And then those who are of the attempt survivor and those who are loss survivors in those communities, they find it very stigmatizing and very demoralizing, because our loved one, it's minimizing their pain or the mental health challenge they were experiencing, or the substance use disorder that they were living with, and it ascribes as though they were operating with a fully formed, healthy, functioning brain. This is a brain whose thinking has gone askew. Yeah. And that's why I have so much compassion for someone why I personally have compassion for someone who is thinking about ending their life or has had thoughts of ending their life. Because I'm a suicide attempt survivor myself, back in 1998, so long-time survivor, but I have so much empathy and understanding and appreciation for how my thought process was not rational. My brain was lying to my experience was my brain was lying to me, telling me that the world would be better off without me. The mantra in my head, I was worth more dead than I was alive. And those weren't correct thoughts for myself. And so I don't ever want to ascribe that if I had a healthy brain, now that I have a healthy brain, or a healthier brain, I don't have those thoughts. And so that's why.
Well, thank you for sharing your story, or a little bit of it, but then also for educating, because, I think that there's so much overlap between, the suicide prevention field and the substance use prevention field, thinking about how we can destigmatize, how we can reduce prejudice, how we can talk about it, how talking about drugs to kiddos is not going to make them start using drugs. Similarly, talking about suicide and mental health is not going, research shows this, is not going to
Correct.
put thoughts in people's minds that weren't there before. If anything, it's going to make them feel seen and heard. So that is a perfect segue to my next question, and this is for either of you. So, already in the short time that we've been talking, this is tough stuff that we're talking about, right? We're talking about people really thinking that they would be better off not here. And it is gruesome and it is sad and it is heart wrenching and it is you can't wrap your brain around it. If you know of somebody who has died by suicide, you keep looking for the signs and it's you feel very guilty. All of which are normal feelings, by the way, but
Right.
it's a lot. This field, your subspecialty field, is a lot. So could you please put to rest some of those myths about how talking about suicide and asking someone, are you thinking of hurting yourself? Like, correct me if I'm wrong, but you've got to be explicit to somebody. Like,
Mm-hmm.
you can't dance around it and be like, are you okay? Like, how are you feeling today? Like, asking the question is one of the most life-saving tools that you can have, correct?
Absolutely. Absolutely. So, and even I just heard you say, have you thought about hurting yourself or harming yourself? We even go more specific and say, harming and hurting yourself, that's survivable. Suicide and killing yourself,
Right.
that's unsurvivable. There's no coming back from that. So we encourage the question, are you thinking of suicide? Have you had thoughts of killing yourself? Have you
Like,
ever
you've got to
wished?
just say it. You got to
Yeah.
say it.
And then another evidence-based question that has proved to be an effective way of asking is, have you ever wished you could go to sleep and not
And
wake
never
up?
wake up.
Because that is a degree of suicidality, the way that process is. It's suicide, the reasons for someone's suicidality is very complex. It's very individual. It's multi-layered. And so it's never just one reason or one factor that contributes to someone having suicide thoughts. Um, and it's very normal. Well, I don't want to say it's normal. It's very common for young children, teenagers, young adults, midlife adults, the elderly, to have thoughts of, what would the world be like if I
Right.
weren't here anymore?
I mean, I've had those thoughts. That doesn't
Right.
mean I'm suicidal. That means
Right.
I wonder what it would be like for my family if I wasn't here. I
Yes.
wonder what would happen. Like, that is but you don't if I mean, I'm sharing that with you all today, and I'm sure there are people who have known me for forever who are listening to this going, "Oh my gosh, I can't believe that Nicole has had those thoughts." Well, I think a lot of people have had those thoughts but don't know how to express them.
Right. And
And it doesn't
the
mean that I'm going to, you know, die by
act.
suicide, act
Right.
on it. It means I'm
Yeah.
thinking about
Yeah.
what that would mean.
Yes. You know, it is it is normal to consider, to a degree, how would I problem solve this situation?
Right.
And when someone who is struggling with many different life challenges, a loss of some kind, going through a divorce, or
Economic challenges.
economic loss, or mobility, personal autonomy loss, maybe I have a chronic health condition and I'm
Oh,
not
yeah.
able to function as I have in the past. Um, all of these life factors that we all experience, it would not at all be unusual to problem solve. How do I adjust to this or for this? How do I integrate this into my life, from being proactive, taking medication for it, seeking help, adjusting my life, and all the way through that problem solving motion of what if I was no longer here anymore?
Right.
Okay, that would be normal. And even if in a process of I hurt, my brain hurts, my heart hurts, my emotion hurts, my body physically hurts from
It's a pain,
all of
some
the
sort
weight
pain.
of the pain I'm carrying, and I can't do this anymore. I don't want to live like this anymore, and I'm desperate enough to think of ways of ending my life. That's, to me, there's a sense of I can have so much empathy for that thought process. And as a community, as a society, I'm not afraid of those thoughts. And I want to tell parents, don't be afraid
Right.
of your children having those thoughts or of you having those thoughts. It's when those thoughts transition to action and behavior that, boy, what do we have in place to stop the action or the behavior? We can treat the thoughts. We can improve the circumstances that create those thoughts.
Right.
But also we can create living environments so it makes it more difficult for our loved one when they're by themselves or in a moment of absolute distraught despair that they cannot engage in the behavior.
So I know you haven't, listened to this podcast before. And I actually kind of love that because it's kind of a chance for me to explain a little bit more about me and like kind of the behind the scenes. But like, at Prevent Ed, like we do a lot of the overlap between the two, the trauma that is leading to someone to misuse substances or use them to cope, or also like the trauma that exists that might lead people to consider suicide, or maybe and it could be also an accidental suicide.
Absolutely.
Right. And so there's a lot of that conversation. So back in right when mental health first aid came out, we all staff got trained, and this was mid 2000s. And I think it was through Liz Sale and the folks at like BHR or NAMI or something like that. And we had to do dyads, where you probably know this part of the training, where you actually have to practice asking someone, are you thinking of suicide? Are you thinking of dying? Like you have to say it, because until you've said it, you don't know what it's like to say it. And at Prevent Ed, we teach young people and adults how to talk to their loved one and say, like, I'm really concerned about you. Like, I'm really, like, your drug usage is impacting me, and it makes me sad and it makes me scared. And so it's like having those conversations and practicing those. Yes, it feels like so weird, right? Like you're like practicing it and it's like it feels awkward and uncomfortable. But then when you actually have to utter those words, you're prepared. And I, unfortunately, and I know I'm not alone, have had to ask the question more times than I can even count, to loved ones, to friends, to partners. And only because I had had that training, and only because I had the tools in my toolbox, was I able to find the words to say, I'm really worried about you. Are you thinking of dying? Like, are you thinking of committing suicide at that time? But it's because I had the tools in my toolbox. And I'd imagine that that is such a huge part of what you all do, is give parents and families the tools in their toolbox that hopefully they never need.
Right.
But if they need them, they will have them.
Absolutely.
And
Shanna,
it wasn't that,
yeah,
it wasn't that long ago that I found myself in that exact situation with a family member that was struggling and expressing to me how much she was struggling. And thankfully, I had been exposed to the program that we teach now, Conversations for Suicide Safer Homes, and had practiced asking the question. And I knew that I knew how to ask the question, and I had enough confidence because it is a horrible question to have to utter to anyone,
Of course.
especially someone that you care about. But I asked, and the person assured me that no, suicide was not on her direct mind right then. But I also know there's a firearm in the home. So that was my next question. Where's your gun? And her husband had already put it in the gun safe and changed the combination and did not give it to her.
So it
So,
was a concern that the husband recognized.
yes, yes.
Wow.
And I was very happy to know that they were proactive like that already without, but a lot of people don't think about that firearm in their home
No.
and just how having one there and accessible, and if somebody's in that moment of crisis, and that's usually what it is a moment of crisis. It's not, when a person's considering suicide and they're to that point where they're ready to act, it's not a long amount of time. I think 12, 13 minutes. Katie, is that
The average, less than 10 minutes.
less than
What?
10 minutes?
Less than
What?
10 minutes.
Say that.
So
I'm sorry. Help me understand that. Say that again, please. Because I think in popular, in media,
Mm-hmm.
I think perception that media tells us is that people write notes and have these elaborate plans and have been thinking about it for a long time. And while I'm sure that that might be the case sometimes, say that again, what you just said.
So the suicide crisis is relatively brief. You're correct in that someone can be having thoughts about suicide for weeks and months and years before they ever engage in the behavior. But there was a study done in the early 2000s. They asked near lethal attempt survivors how much time transpired in that suicide crisis between deciding you were going to end your life and engaging in the behaviors. Something like 47% said it was less than an hour that they'd made the decision to they were engaging in the suicide attempt, and a quarter more said it was less than 5 minutes. And then a subsequent study found that on average it was less than 10 minutes.
That is frightening.
Yeah. So when you think about what, a young person having access to their parents' firearms in the home, or, we're a hunting society here in Missouri. They may have their own hunting firearm,
Right?
their own
Right?
rifle that they're allowed to keep control over. How quickly they would be able to load that firearm and pull the trigger without any interruption. And once the trigger's pulled, you can't stop that bullet.
Right.
There's no pulling back on it. And so that's what we're talking about is preparing and being proactive so that there's that 10-minute suicide crisis can't happen, so that they can't get their hands on the most lethal method.
So where are you all giving this information? Is it through media campaigns? Is it in churches, parent meetings at schools? How can people hear about this and really get tapped in?
we have
I'll let you answer that.
yep, we have a 1 hour presentation, Conversations for Suicide Safer Homes, that we are promoting all around the state. We have field coordinators that work in the St. Louis area. We have some gentlemen that are out west a little bit in the state. I'm down in southeast Missouri. I reside down in Madison County, and I'm available to make the presentation anywhere from St. Louis to the Boot Heel. So we have 4 populations that we're really trying to get this information to. Trying to get that Conversations for Suicide Safer Homes program too. It's a 1 hour program.
Who are the target populations?
We are trying to work with first responders,
Yep.
police officers, firefighters, ambulance drivers.
Who have access and trauma.
Yes.
Right.
Yes. Okay. So that's group number one. Who's
Yep.
group number two?
We are also trying to reach faith-based leaders and communities.
Okay.
When some people, when they're struggling with mental health issues, suicidal thoughts, they turn to their church.
That's right.
And if we,
Especially rural, but
yep,
also communities of color. And yeah,
Yep.
absolutely.
yep.
Great.
And if
Okay.
we can get those faith-based leaders to understand the importance of lethal means reduction and
Yeah.
hopefully put that into their toolbox when they're faced with those conversations, we
Right.
can
Okay.
help
Group
save
number
lives that
three.
way. The construction industry, folks that work in the construction industry.
This is why John Gall knows you and told me to call you.
Yeah.
Okay. And we've had lots of conversations on this podcast about how the construction industry is so at risk. They're dealing with pain, they're pushing through the pain, mental and physical. If they don't show up to work, they don't get paid. There's a lot of machismo. You've got to be tough, you've got to handle it. We've had Brandon Anderson on from
Yeah.
AGC. We've talked about stand down for suicides. Talked about peer workforce and how it's okay to not be okay. So love and Missouri's really on the forefront of that, which I don't think a lot of people know, that like a lot of the research and the work that's addressing construction industry is coming from Missouri. I mean, it's pretty incredible, actually.
They really are at the forefront and driving the enthusiasm that we are seeing grow. It is so fun to watch and go to their summits.
I agree.
Because they're so passionate about suicide
I
prevention.
agree.
So it's where the rubber meets the road. I love it.
So I've shared this before, but I grew up in a construction family. So my dad was in construction, uncle's in construction, saw what it was like to deal with problems. And it usually meant, cracking a beer and
Yeah.
shooting the breeze and not really talking about anything substantive. Right.
Yeah, absolutely.
Shanna, who's the fourth group?
The fourth population is veterans and their family members. Veterans and family members, they're at a
Again, that
greater
would probably
increase.
be access and trauma.
Yep.
Access and trauma. The all those three populations, the construction trades, the veterans, the first responders, they have all the same risk factors as anyone else for suicide, but the frequency and the degree to which the risk factors occur in their life is heightened because of the exposure that they have.
And I think I can say this, but those three professions or groups are male dominated. And so one thing I learned a long time ago, and I'm wondering if from Liz Sale, and I'm wondering if it still holds true, is that everyone's at risk, right? But the group kind of most at risk are older white men.
Middle-aged white men.
Yes.
And particularly if they own firearms, simply because they have access to the most lethal means. Yeah. They are the most at risk. And here in Missouri, it's middle-aged white men living in rural areas with limited access and resources to help, perhaps cultural beliefs that don't support help-seeking behaviors, or they don't have access to adequate healthcare services or behavioral healthcare services. They are particularly at increased risk.
So when I learned that from Liz a long time ago, one of the things she said to me that kind of struck me was that sometimes too there's an increased risk with an older white male who is used to working for their entire life and then retires or has a workplace accident and is used to working and providing and doing the thing. And then when that no longer happens, they have a real sort of crisis of confidence. I'm curious if that still holds true statistically, because I think anecdotally, I know that my antennas start to go up when the white men in my life who are retiring, who are kind of like feel a general malaise and just kind of stop
What's my,
caring.
yeah.
Yeah.
It's that loss of, do I have a sense of purpose?
Yeah. Right.
Who am I if I am no longer fill in the
Correct.
blank?
Right.
What I've become a burden to my loved ones now that I have lost this portion of my identity. Now, certainly not all of them, if they
Sure.
can
Sure.
successfully transition, but if you stay stuck and your brain starts lying to you that there is no hope, there is no purpose, I'm a drain on my family, my body hurts, I have nothing to contribute. You can see the downward spiral
Totally.
in those words, in that thought process.
Shanna, is this 1 hour presentation? I mean, I'm sure it just costs gobs of money, right?
You're wrong, Nicole.
I love being wrong.
This Conversations for Suicide Safer Homes, we bring it out 100% free. It does not cost participants anything. It does not cost an agency to have us come in. Most of our instructors are certified, where a lot of the first responders can get post credit or continuing education units.
Love it.
Right, things that they need to keep up with for their licensures that we can offer for those courses, attending those courses. So that's an added bonus and free as well.
And how would they find out, Shanna? Where would they go to if people are listening that want this?
Saferhomescollaborative .org. Is it org or com? Org. Saferhomescollaborative.org.
.org. Okay.
That's our website, and you can scroll on down to trainings. There's a list of trainings, and there's a contact us button as well.
All right.
Katie does virtual presentations. They can, yep.
They can contact us on the website, or they can email us also at info@saferhomescollaborative.org. And what has helped us to be able to spread the message across the state is not in addition to our employees that we have through MIMH, we've trained partners, about 75 instructors all around the state of Missouri. So if you are out in Greene County, or you're in Jackson County, or up in Northwest Missouri, and you would like to have this training brought into your community, we can partner with one of our instructors from outside of MIMH, from outside of our internal team, to coordinate with you to bring in the training Conversations for Suicide Safer Homes.
Is this a national program, or is this a Missouri thing?
Conversations for Suicide Safer Homes is a Missouri specific training, but we created it in partnership with Elaine Frank and Kathy Barber, who were the original creators of Counseling on Access to Lethal Means. That was originally a 3-hour training for behavioral health and emergency room professionals who were doing in clinic or in the emergency department suicide risk assessments. So we worked with Elaine to adapt it for gun owners here in Missouri. So we're affiliated with, we're a Calm Informed training. So we are, yes, specific for Missouri.
So I wouldn't be doing my job before I let you go, if I did not ask how you all take care of yourselves.
Oh.
Because obviously this is a tough topic, and talking about heavy stuff all day, every day is a lot. And, I know what it's like to have people pour their hearts out to you, and it's heavy. So and it should be, because it's very important. Right.
Right.
But I would like to know what you both do. Shanna, I'm going to start with you. What do you do to put your own oxygen mask on and take care of yourself at the end of the day?
Well, Nicole, I love Tai Chi. I had the opportunity about 6 years ago to be trained as a Tai Chi instructor for my position I had then. And I fell in love with the practice, and I practice Tai Chi. It's wonderful for the mind, body, and soul.
Oh my gosh, I love that. I took a class once and I was like obsessed with it. I like went down a hole where I like was obsessed with it. And then first, I don't even know why I fell out of it, but that is so cool. Okay, awesome. Katie, how about you?
Well, I wish my self-care was as cool as Shanna's. But you know those nationwide commercials where, or whatever it is, where they're becoming your parents.
Yeah. Oh my
Becoming
gosh.
my parents. And I find getting outside, I'm trying to grow grass. So watching grass babies grow is, we have a bumblebee that loves to pollinate my flowers. Sitting and watching that bumblebee sip the nectar is the best kind of self-care. Touching dirt.
Do you do that grounding thing where you like take your shoes off and you like, right? Do you do that? I do. I do it.
I don't do it.
It is the easiest.
Yeah. Pulling weeds.
Easiest form of self-care.
Yeah. That's been my go-to lately, while I'm also plugged into true crime podcasts or a book, or, just, but you know what, I'm no longer so much in the fire, in the trenches, and every day hearing the heaviness of things. Unfortunately, I was there. I'm not there. I'm removed from it now. And now it is just so, I get so much excitement and invigoration, and my passion builds and grows when I hear stories about, and it helps me validate that I'm doing what I'm supposed to do. When we hear stories like Shanna shared, where she recognized it, she asked the question, she asked about the firearm had already been taken care of. That's a yes for myself. That's my well-being. That's what I love to hear. Or I won't name names, but there was an individual who I had shared lethal means safety with, the concept, what we were trying to accomplish on an airplane 3 years ago, and there was some skepticism. The you're never going to get their guns, and now they are all bought in. They're like, they were giving it back to me, and I'm like, oh, that is a full circle moment.
That's right. And those don't come all the time. And those take, sometimes you're planting a lot of seeds. But when it happens, it's a beautiful thing. I would say, Katie, pulling weeds is not boring. I went through a really tough time a couple of years ago, and with a divorce and all kinds of stuff. And my coping mechanism was getting out in the garden, in the dirt, and sometimes at like 9:30 at night, and I'm just pulling weeds and I'm getting it out and done. Oh, hi, Tim. Could you leave for 1 second, and I'm going to let you in just a few minutes.
That's fine.
Okay, thank you.
Mm-hmm.
But it is, I think there is something about movement and all the things that just really make a huge difference. So,
agreed.
Tai Chi is cool. So is gardening and watching the bees, as far as I'm concerned. Tim, why don't you stay on, because this is a really great
I'm not sure how to get off. I'm sorry.
That's all right. You stay on. Katie and Shanna, do you know Tim?
We were at the Mental Health Summit at the Liuna building earlier this month.
Yes.
Yeah, and he shared his story then. And so we didn't meet, but we've heard a portion of his story. So,
well, okay.
Oh.
Well, he's on next. He's on next. So seriously, really and truthfully, like, thank you for what you do. You both are quite literally saving lives. You know, I know that some people, that's like just what you say, you know, but like you're actually doing it. It's a tough.
Well, I like to think
job.
that I'm empowering people to go out and save lives.
There you go. There you go.
That's,
There you go.
yeah.
And Shanna, you are doing that too. You are giving people the tools and the conversation tips and the resources to be able to save lives. That's exactly right. That's exactly
And
right.
our whole team at the Safer Homes Collaborative, we're all working towards that goal. So
Yeah,
there's a lot more than just
effort.
Katie and I.
Yeah.
Yeah.
Thank you so much for coming today. If you liked what you heard, and really, like, I know that you did, please consider rating, reviewing, and subscribing to the Preventable. Reach out to the Safer Homes Collaborative if you are interested in a presentation, particularly, like, I'm thinking about this audience. Like, we have a lot of first responders that listen. We have a lot of people who are in faith communities, you know, a lot of folks in the construction industry. I know that you all are tapped in, but if you want to lean more in, like, bring it to your school, bring it to your church, bring it to whatever, like, these are the women. So thank you so much for spending time with me today.
Thank you for having us.
Thank you.
Thanks for joining us at The Preventable, brought to you ad-free by Prevent+Ed. Prevent+Ed works to reduce or prevent the harms of alcohol and other drug use through education, intervention, and advocacy. Please visit their website at prevented.org. Like what you heard? Rate, review, and subscribe to stay up to date with what we are serving on The Preventable.